Hello everyone, welcome to another session in the series Daily Dentistry Demystified by Endo Haveli. Before I start my session, I would like to acknowledge the support and coordination offered by Dr. Shashank Unial. Myself, Dr. Vijit Narayana, I completed BDS and MDS from Government Dental College, Thiruvananthapuram in 2006 and 2011 respectively. Presently practicing at our clinic, Innocent Smiles Dental Clinic at Kochi, with my wife, Dr. Kavita Kumar, who is a pediatric and preventive dentist. So, warm greetings to everyone from God's own country, Kerala. Hope everyone is safe and healthy in the confines of their home. With this, let's start the topic of the day, light curing composite. Don't take it lightly. I'll start off the session with one of the most memorable scenes in the history of Bollywood. Everything ends in a happy note, implying that they lived happily ever after. But is it really so? No, the real challenge is yet to begin. And so is this slide, and the new light cure. Everything may seem so simple after this. Majority of the discussions on composites have only this slide dedicated to curing. We come across numerous discussions and presentations explaining other aspects of composite restoration, introducing newer materials, better techniques, and finer instruments. But seldom is there any mention about light curing, except the intensity of light and the time of exposure. Today, we will try to demystify some of the relevant aspects of light curing. Before we go into the details, let's brush up some of the basics of polymerization. Composites undergo polymerization basically by two methods. The first one is self or chemical polymerization, and the second one is light or photo-initiated polymerization. Since today's topic of discussion is on light cure, let's see what happens in a photo-initiated polymerization. Any light cure material has a photosensitizer and an amine initiator. When light of a particular wavelength falls on the photosensitizer, it gets activated. This activated photosensitizer interacts with the amine initiator to produce free radicals, and this free radical is what starts the addition polymerization. The most commonly and widely used photosensitizer is camphoroquinone. It absorbs light at around 468-470 nanometers. A drawback of camphoroquinone is its bright yellow color. It imparts a yellow color to the resulting restorations also. With the increasing popularity of bleach white shades and more translucent bulk fill composites, a need for alternate photosensitizers arised. These are some of the commonly used photosensitizers that are used in combination with camphoroquinone, leucerin TPO, phenylpropanedione, and ivosirin. In this slide, you can see the absorption spectrum of various photosensitizers that are used at present. Now we will go through a couple of terms that are frequently used with curing of composites. The first one is the degree of conversion. It is nothing but the percentage of monomer that converts to polymer on curing. Practically, it is around 55 to 65% with any light cure composite resin. With pure light curing, it goes even below. The second term is depth of cure. Depth of cure refers to the depth to which the curing light causes polymerization, directly related to the depth of penetration of light. The depth of penetration is in turn directly related to the wavelength of light. Longer the wavelength, greater is the depth of penetration of the light. For blue light, the depth of cure in composite is around 2 millimeters. Having set the background, now let's see why curing is critical. Curing of composite is one of the most critical steps in composite restoration, if not the most. In spite of that, it is the most neglected steps. Sometimes even so much that the job is entrusted to assistants, while the dentist is involved in some other steps. So before we proceed further, it is important to realize the consequences of inadequate curing. What are the consequences of inadequate light curing? Inadequate light curing affects the performance of restoration in every possible way. It reduces the bond strength, increases micro leakage, postoperative sensitivity, pulpal toxicity, chances of recurrent caries, lack of color stability, and poor mechanical properties which can lead to wear and fracture of restoration. So now the question is how to achieve optimum light cure. Unfortunately, there are no clear-cut clinical criteria to objectively analyze the adequacy of light curing. A surface that is hard to touch cannot be considered as a criteria for adequate light curing. Moreover, deeper layers may not be as much cured as the surface of the restoration. So how to achieve or ensure optimum light cure? The secret lies in the successful management of all the variables that are associated with light curing. So what are the variables that are associated with light curing? As identified by Dr. Richard Price in 2010, he enlisted them as core variables. And these are the core variables. C stands for curing light characteristics, O stands for operator technique, R stands for restoration characteristics, and E stands for energy requirement of composites. Let's go through each of the variables. Curing light. As on date, there are numerous companies coming up with even more number of models of curing lights. At present, curing lights are easily available from well under 2.5k to approximately or even more than 2.5 lakhs. Of course, not all are equal, but what are the basic criteria that is needed to be analyzed before investing in one such machine? So these are the curing light characteristics that we need to analyze. That is the irradiance. The second one is diameter of light guide tip. Third is the spectral irradiance. Fourth is the uniformity of irradiance across the diameter of the tip. And fifth one is the quality of the beam that is emitted. So let's go through each of these curing light characteristics. Irradiance, which is sometimes mistakenly called as intensity. Though it cannot completely describe the quality or the curability of the light, it is the most common way to describe the light output from the tip. It is described as the power output per unit area. With newer lights claiming 1 second curing, the value of irradiance goes up to or even more than 3000 milliwatts per centimeter square. Though the acceptable minimum range of irradiance is around 600 to 1000 milliwatts per centimeter square. Irradiance is normally measured using a radiometer, which is either supplied with the light or has to be bought separately. It is a very important tool to calibrate or analyze the condition of the light, as will be discussed later. The second characteristic is the diameter of the light guide tip. So how does diameter influence curability? As seen in the picture, smaller diameter light will not cover the entire surface of the restoration. As a result, multiple exposures have to be done, overlapping the previously cured area to cure the entire restoration. Normally, a light guide tip diameter of less than 9 millimeters is considered to be too small. So some lights come with multiple tips so that they can be interchanged as per the need. Coming to beam profile. Beam profile is the uniformity of the irradiance over the surface of the light tip. As seen here, you can see three patterns of beam profiles. The first one, which is considered to be optimally distributed, the yellow part is uniformly spread across the diameter. In the second and third picture, only small part of the beam profile is yellow and it is called as the hot spot. The rest of the light is unfit for curing and is designated as cold spot. Only that part of the restoration that is irradiated with proper intensity cures the composite. The rest of the composite remains uncured. To overcome this kind of issues, some authors have suggested constant movement of light cure over the restoration throughout the curing time. And this should be followed for lights whose beam profile is not known. Of course, in such cases, the total time of exposure need to be increased. Another characteristic of curing light is the quality of beam or the beam divergence. If the beam is highly divergent, it can lead to significant loss of irradiance with distance. Collimated beams diverge minimally and hence loss of irradiance is also minimal. This is extremely important when the depth of cavity is at a distance from the surface of the light. We'll come to it in some time. Is your curing light collimated or divergent? Check out this simple test suggested by Dr. Johann Chaco in the link below. Spectral output. Traditional LEDs emit light of predominantly one wavelength, that is around 465 to 470 nanometers. As mentioned earlier in the presentation, there is an increasing popularity of newer photosensitizers which requires wavelengths different from that of camphoroquinone. To satisfy such composites, most major manufacturers are marketing lights that emit two or more wavelengths. Present data is not confirmatory regarding the advantage of such lights over the traditional lights. Coming to the next variable in core variables, it's the operator technique, which includes position of light and modified curing techniques. Position of light can further depend upon the distance of the tip from the substrate and the orientation or angulation of the light tip in relation to the surface of the substrate. Coming to the distance of the light tip from the restoration, the light tip should be kept as close as possible to the restoration. With increasing distance, irradiance decreases drastically. In certain unavoidable situations, like a deep proximal cavity, it may not be possible to place the light source close to the restoration. More so if the matrix system also interferes with the light placement. In such cases, the lack of proximity of the light may be compensated by increased curing time. Angulation of the tip. It is always desirable to keep the tip parallel to the surface of the restoration being cured. Any angulation can drastically reduce the intensity of the light, thereby compromising the degree of curing. Modified curing techniques. Though not included in Richard Price's recommendation, I have included these in the operator techniques because there are numerous studies that appear to show that modified curing methods have beneficial effect on the polymerization of composite restorations. All composites shrink on polymerization. If not well managed, it can cause stress at the restoration margins. A few modifications in curing techniques can help minimize the ill effects of polymerization shrinkage. An example of one such modification is the soft start polymerization and its variations like pulse delay and ramped curing. When curing light falls on the composite, it polymerizes and undergoes volumetric shrinkage. It has been shown that the shrinkage occurs towards the source of the light, and this movement towards the source of the light causes stress at the resin-dentine interface. But if the rate of conversion of monomer to polymer is slow, as in the soft start polymerization, it gives time for the yet unreacted monomer to flow to the area of stress, thus relieving the stress at the resin-dentine interface. Another technique to minimize the effect of volumetric shrinkage is to modify the placement of curing light. Here, the curing light is first placed on the walls of the preparation so that the initial shrinkage occurs towards the source of the light, and so there is no stress at the resin-dentine interface. Then the restoration is cured from the occlusal surface. The third factor in core variables is the restoration characteristics. Certain light designs may not easily access the restoration that is posteriorly placed. Certain cavities may not be easily accessible to the curing light tip. Anatomic limitations and restricted mouth opening may further complicate the issue. In such cases, adjustments must be made in patient position such that access and visibility is not compromised. Increasing the curing time can compensate for the lack of access to some extent. Alternate restorative materials should also be considered if adequate light curing cannot be guaranteed. The fourth in core variables is the curing energy or the energy requirements. Light cured composites polymerize based on the amount of light energy that is received. The energy is calculated as the product of irradiance and time of exposure. It is expressed in joules per centimeter square. The energy requirements of composites vary based on various factors like manufacturer, shade of the composite. Very dark and bleach shades need more energy to polymerize. Then it varies based on opacity. It varies based on filler content. Flowable composites need higher energy to polymerize. Filler size, the microfill composites need higher energy to polymerize, and on the bulk of material. A 2 millimeter thick layer of composite may require 6 to 24 joules per centimeter square of energy. Extended curing time. Many times, to meet the energy requirement, operator may have to extend the curing time beyond the recommendations of the manufacturer. As has been said, composite may remain undercured but can never be overcured. So it's always advisable to cure a bit longer than what is felt sufficient. But additional curing time can lead to excessive rise in temperature. So caution has to be exercised while doing so. Excessive rise in temperature can be prevented by curing with intermittent stops in between. For example, a 10-second curing followed by a 2-second break. So a 30-second curing cycle can be done with 3 10-second sessions with 2-second break in between rather than 30-second cycle in a single stretch. Another technique by which excessive temperature rise can be prevented is by simultaneous air cooling using a three-way syringe while the restoration is being cured. Now, having said about the management of core variables, let us move on to the maintenance of curing light. Curing lights should be maintained clean. The tip should be free of any contaminants. Remnant composites stuck on the tip interferes with the irradiance, leading to inadequate curing. Similarly, any damage to the light tip, like cracks, can cause light leaks, which again can decrease the effective irradiance. It is also a good idea to do periodic checks of irradiance. It can be done using the radiometer. Though not an accurate measurement, it helps to identify the loss of intensity over time. Visual evaluation of intensity is not at all reliable. Mere presence of blue light is not an indication of curability of the light. Another technique that is used to check the intensity is test cure a block of composite. Manufacturers sometimes provide such templates along with the curing light. These templates can be filled with composite and light cured for stipulated amount of time. After the light curing is done, the template can be inverted and the cured composite can be scraped using a sharp instrument. Again, not an accurate measurement of adequacy of curing. It helps to identify the loss of intensity of the light over time. Then about charging the light cure. It is always good to maintain a nearly full charge in battery. Even though most of the contemporary units have lithium ion batteries which are more stable, durable and provides reliable output over extended clinical operation time. Studies have shown that with decrease in electrical charge, the irradiance reduces drastically. So it may be a good idea to charge the light probably even after every use or at least regularly, not waiting for the battery to drain. Infection control. Need for infection control and prevention of cross-contamination cannot be better explained than the present situation that we are in. Always use a sleeve while using light cure, or wrap using a cling film or a food wrap that is disposed after every use. Using a sleeve that does not interfere with irradiance significantly is important. Slight reduction in values of irradiance is normal. Light cure units can also be wiped clean using disinfectants as per the manufacturer's recommendation. Alcohol-based wipes are normally considered acceptable. Light cure units are generally thought to be safe and used without much care or due attention. In fact, studies show that the high intensity blue lights are not safe for eyes. The high intensity blue light can cause irreversible retinal burning. Chronic low level exposure also can lead to accelerated retinal aging and degeneration. The extent of damage is even more with operators who have undergone surgery for cataract. So how to protect yourself? One of the common technique employed is to position the light over the area to be cured, switch on the light, confirm that it is irradiating the area correctly, and then look away. But studies have shown that even short exposures like these can cause significant damage in the long run. Moreover, by looking away, you cannot ensure proper positioning of the light for complete curing time. So what is the solution? Use of orange filters or the so-called blue blockers are highly effective in protecting the eyes. I normally prefer the larger ones which are used during the light curing. It helps to maintain position of the curing light because it allows you to see the curing light during the entire curing time. To summarize, adequate curing of restoration is essential for its long-term service. Even the best of materials and techniques fail if curing is improper. Curing is a multifactorial process that needs optimum integration of good light and proper technique. Also, the possible hazards both to the patient and the operator has to be taken care of. So next time you buy a curing light, it would be a good idea to visit the manufacturer's website, learn about the product, and then buy. So we have come to the end of my presentation, and these are my references. So wish you all a happy curing, maintain social distancing, and stay safe. I would like to take this opportunity to thank my teachers, Dr. Eno Varghese and Dr. Jolly Mary Varghese. Also, a big thanks to Dr. Prashant Dhanpal for providing me with all the necessary literature for this presentation. Dr. George Jacob for being a constant source of inspiration, and Dr. Liba Varghese for her support and encouragement all throughout. And last but not the least, a big thanks to my wife, Dr. Kavita Kumar, and my daughter Anika for standing beside me. And you can post your queries in the comment section, or you can contact me directly on my WhatsApp number or through my Facebook page, Cutting Edge Dentistry. So once again, thanking you all for your patient listening. Stay safe, stay healthy, stay fit. Thank you.